Okay, so I'm starting off by doing my machine checkout. So I've wiped everything down and I've done the full checkout, and I'm going to do the circuit test. No leak. It's already on bag mode, and set this back to minimum. Bless you. Bless you.
Diet.
So I'm setting up. I have my suction is set up. I have my airway. Just was notified of a 30-year-old patient coming in, got into a fight at the gym, and his jaw looks like it's broken. So they are doing an X-ray now to see if there's any other fractures in his face. So currently I'm preparing to do nasal intubation. So I have my equipment set up, and I have extra an LMA, an oral airway, and a nasal trumpet, as well as the nasal ray tube, and I also do have a backup PT tube in the drawer, and my my blade, and I also have we're gonna do a video laryngoscopy when we do the nasal intubation. On top of that, I have all my my medication set up, and I have tape. I think he has an IV, but we'll make sure that he has at least one IV before we begin, and my drugs, and then I have emergency airway equipment in my ambu bag, and everything is set up. So I'm gonna go meet my patient in the ED. Thanks. Okay, so I'm in the ER meeting my patient. He's a 70 kg, 30 pound male who was at the gym and got into a fight. He told me he doesn't appear to be under the influence of anything. We are gonna attempt to get a urine tox before we go back to surgery, but other labs I would get would be just a basic BMP and a type and cross in case there's any, there's an expected blood loss more than 150 cc's, but it is vascular area, so we would just type and cross him just in case. And so I meet him, I verify his age, his birthday, his name, sign consents, because he's in a lot of pain and is somewhat agitated and not really able to open his mouth very much. It's difficult to do an airway assessment, but he is cooperative, and I'm able to at least ask him the basic yes/no questions. There doesn't seem to be any family history of any problems under anesthesia, and he has not had a surgical history, and no allergies that he's aware of to latex or anything else. He doesn't take any other home meds, although he does say that he takes vitamin supplements for working out. So we're just going to check the BMP on that, make sure everything's expected to be within normal limits. And I'm going to go ahead, because he is a little bit agitated and in a lot of pain, we're going to go ahead and give him 2 milligrams of Versed now, and we're going to give him 25 of fentanyl just to kind of relax him a little bit and let him, the nurses keep, he has an IV in, and we're going to roll back to surgery now. Okay, so we are back in the OR, and the bed is locked. We're having the patient move from the stretcher over to the OR table, and we're going to go ahead and connect him to the O2 sat, blood pressure cuff, and EKG leads. But this time I'm going to give him a spray of Afrin in each nair, and ask him if there's a nair one over the other that he can breathe better out of or would prefer to be intubated in. And we are ready for induction, so I am going to just have him, he's considered an RSI because he was at the gym when this happened. It's considered a trauma, and he had eaten dinner a couple hours ago. So I'm not going to bag him, but I'm gonna just let him breathe with my flows on. And this is not actually on, that was a joke. Okay, so I already gave him Versed in ED, so at this time I'm gonna go ahead and make sure that his IV is connected to his what's gonna be his maintenance fluids. And I'm gonna start by giving him 100 mics of fentanyl. I'm giving him 70 milligrams of lidocaine. I'm giving him 0.5 cc's or 5 milligrams of rock. And because he is a RSI, I'm gonna ask my assistant to give me some crike pressure, and then I'm going to give him 140 milligrams of propofol and 140 milligrams of Sux. And I'm looking for loss of lash reflex, and when I say that I've achieved that, I'm going to tape his eyes. I'm going to scissor the mouth. I'm using video laryngoscopy and making sure to keep the forceps off the cuff. I am going to pull back a little bit. Okay, now forward. Okay, good. Okay, and we are in. And I'm going to put this on a dirty towel. I'm going to inflate my cuff. And I'm going to connect, and I'm going to bag the patient and look for chest rise and look at the monitor, make sure that ETCO2 I'm getting positive waveforms and his O2 sat, and check for fog in the tube. And I do have that, so I'm going to flip over to vent and cut my CBO on. He weighs 70 kg, so he would have a tidal volume of 500, respiratory rate of 12, IE is 2, PEEP of 5, and he's on a pressure control volume guarantee. And at this time, I'm going to cut down my oxygen a little bit and secure my tube with tape. And this is going to be a shared airway, and the table will be turned at about 90 degrees or 180 degrees, so I would have an accordion on. And we've secured the tube. And okay. And it goes on to numb. And we are getting ready for incision. I'm going to give him 2 grams of Ancef, and we can begin draping and putting the bear hugger on and getting ready for surgeon to begin the procedure. Okay, so we are preparing for incision, so I am going to do a check train of 4, and I have 4 out of 4, and then I'm going to go ahead and give the rest of my rock. This is a very stimulating surgery, and also calls for permissive hypotension, so I will be either going higher on my gas or giving propofol and fentanyl doses as needed to monitor his blood pressure and heart rate. His maintenance rate is going to be about 110 cc's an hour. He didn't really have an NPO time, maybe an hour from the time of the fight to surgery, so that's about 110 cc's an hour. So I'll give about 50 the first hour, and then 25 cc's added extra to the next 2 hours. And then as needed, if the surgeon is using any kind of throat pack or anything, I'll be making sure to time those at 20 minutes for a takedown, and making sure I'm keeping track of all of the throat packs. Towards the end of the surgery, I'm going to ask the surgeon to pass an OG tube and suction the contents from his stomach, since he will be a very high risk for PONV. And we also, I will give him a dose of Tylenol. And as we're preparing for the end of the case and they're wiring his jaw shut, I'll be making sure that we have wire cutters available and that they'll be going with him to PACU. And then I'm going to give him Tylenol, and I should have given Decadron at induction, but we'll write that up. So as we're preparing for extubation, I want this to be he needs to be an awake extubation, but I need it to be very smooth. So I'll make sure that I'm trying to decrease a little bit of the use of my opioids, but making sure he's got maybe a antiemetic dose of propofol. But I'm gonna cut my gases down. And I'm going to increase my flows so that he can breathe it off. And we're going to be extubating at 100%. And then I'm going to go ahead and prepare to reverse him. So I'm going to use Sigamidex to make sure he's completely reversed, since I won't be able to, because he's going to have his jaw wired shut. So I'm going to give him 140 milligrams of Sigamidex and wait for him to come back when he's awake and he's able to follow commands. And I'm going to check a train of 4, and then we're going to go ahead and prepare for extubation. So I'm gonna flip him to bag mode and make sure that he's able to pull tidal volumes of at least 300 to 350, and making sure pain is maintained, and blood pressure. He's still cooperating, so I'm going to deflate the cuff. And then I am going to pull on at the end of his inspiration. And then we will just be giving him another breath, making sure that his oxygen saturation, he's not overly coughing, and his jaw is wired shut, but I could suction the sides of his mouth if it looks like he's needing that. And then we'll be rolling to PACU.